Thank you, Suzanne, and welcome everyone to today's webinar. Again, I'm Elaine Arkin, and I'll be facilitating the webinar as a part of the NCCOR Coordinating Center. Just quickly to go over today's agenda, we're delighted to have two spotlight presentations. The first on an evaluation of Let's Go, which is a childhood obesity prevention program at the Barbara Bush Children's Hospital at Maine Medical Center. And the second is on integrating clinical community engagement models, a nationwide children's hospital primary care obesity network. 101, you'll see on the agenda, is an opportunity for you to ask questions of our speakers, so be thinking about those questions. And then at the end of the call, we'll have just a very a brief preview of some upcoming NCCOR events. So before we get started, Suzanne mentioned if you have an issue with your phone, but also if you need any technical assistance or if you have a question for our speakers, if you would type your questions into the chat box on the right. And if it's an issue, then an NCCOR staff person will help you. And if it's a question, it will be saved for the session after our presentations. And finally, once more, a reminder, as Suzanne asked you to please turn down or mute, preferably mute your computer microphone, so that we will not have the background noise. So we'll also be tweeting during today's webinar. If you are on Twitter or other social media, we encourage you to join the conversation by using the hashtag ConnectExplore and following the Twitter handle at NCCOR. Our speakers today are Dr. Victoria Rogers and Ihuoma Eneli, and we are delighted to have both of them. Dr. Rogers is a pediatrician and director of Let's Go, and Dr. Eneli is a professor of pediatrics at Ohio State and director of the Center for Healthy Weight and Nutrition at Nationwide Children's Hospital. So just before we hear from Tori and Eneli, we have just a quick poll for you. If you can, let's see, you should be seeing, there it is. If you would take a minute to quickly answer the poll, and we'll let you know who else is on the phone with you. Okay, well, as you can all see, we have a great range of settings. We appreciate you letting us know and letting the speakers know where you are listening from so that they can know a little bit more about you. So now you'll be hearing more from them. I'd like to turn it over if we can get the poll off. Thank you. Turn it over to Tori for our Spotlight segment on evaluating Let's Go. Tori?
Thank you very much, Elaine. Jackie and I are thrilled to be here today to talk to you about Let's Go. So I hope everybody can hear me. Let me know if you can't. So Let's Go has a vision and mission which is inclusive of all children and strives to reduce obesity by working on environmental and policy change. It's all about children and the families, so Let's Go reaches children from 0 to 18. I will tell you we're very excited about some new work we're going to be doing in the prenatal realm in the coming years, so if you have some time, I'll tell you about that. And Let's Go is all about changing environments. We focus on changing environments and policies wherever children and family live, learn, work, and play, and the program works in these 6 settings. And Let's Go began in Greater Portland in 2006, and we've expanded across Maine and into some neighboring communities in New Hampshire. We're currently working with nearly 1,000 sites, which is, I have to tell you, pretty daunting at times, but also very, very exciting. And we work from the southern tip of Maine all the way to the northern tip of Maine. It's all about healthy habits. Now, I know we're talking about childhood obesity, but at Let's Go, we quickly pivot to healthy habits for lots of reasons. Most importantly, it's the thing that we think helps focuses on positive messaging and positive behavior change. So we use the mnemonic here that we developed here in Maine, 5210, eating 5 or more fruits and vegetables a day, 2 hours or less of recreational screen time, keeping TV and computer out of the bedroom and no screen time under the age of 2, 1 hour or more of physical activity, and 0 sugary drinks, drinking more water. People often ask us, so how in the world do you actually reach 1,000 sites? And so we do it through a very innovative dissemination model with a home office at the Barbara Bush Children's Hospital at Maine Medical Center. That's that center circle that you see there. And we have a staff of about 14 amazing people with expertise in healthy eating and active living, healthcare, quality improvement, evaluation, nutrition, and public health. I'm the only physician on staff, which I think is plenty, to be perfectly honest. But it's really one of the things that's been very important to us to have a very diverse staff that can meet the needs of the populations that we serve. And then how it really works in the community and how Let's Go comes to life is really, really unique, I feel. And so we have this circle, a dissemination partner, and so it's set at the center of that is the Let's Go coordinator. It's one person that we train, and there's sometimes half-time, most times full-times in the different communities. And they are trained again by us to implement Let's Go in their communities. And it's surrounded by a supportive team and a strong backbone organization or entity. And oftentimes these entities are local hospitals. And I can get into a little more of that if people have questions about how they might want to do this in their community. What's also unique is that we developed a 5-step path that we use with all of our registered Let's Go schools, child care, out-of-school, and healthcare sites. So I wanted to walk you through those 5 steps on how a site would be implementing Let's Go. So first of all, we engage a site. Let's Go is a completely voluntary program, so we don't push ourselves on anybody. We might nudge some sites, but we don't push ourselves on anybody. The second step, once we've engaged a site, is our Let's Go coordinator goes in and with somebody who's a champion at that site does an assessment of their environment, and then the champion at that site sets a SMART goal. The third step is to implement evidence-based strategies that I'll talk about in a minute, and those strategies will help them reach their goals. The Let's Go coordinators provide professional development to the staff at each of these sites. And then in step 4, near the end of our program year, which is near the end of the spring, the beginning of the summer, we do an evaluation of all of our sites to look at the environmental and policy changes that have occurred during the year. And then step 5 is very important, really. It says celebrate, and it's to really celebrate the successes that the site has had. We encourage each community to have a community celebration in the fall to celebrate all the great work that has happened and also to think about some areas where the community could improve on in the coming years. And I've had the opportunity over the last 5 years to go all around the state and to meet these people, these amazing people that are working every day to make the environments easier for our kids to eat healthy and move more. And I just so enjoy doing that. So let me tell you a little bit about these, what we call evidence-based strategies. So we have 10 of them. There are 5 priority strategies, and here they are. Things like limiting unhealthy choices for snacks and celebrations, and limiting or eliminating sugar, providing opportunities for physical activity, and limiting recreational screen time. We call these priority strategies because the evidence tells us that these are more likely than other strategies to have a greater impact on healthy eating and active living. And these, so I just go to the next slide here, is the 5 supporting strategies. And these are ones that are equally as important, but we don't think may have as strong evidence to make those changes in the, strong evidence to improve healthy eating and active living. These strategies were really important when we started to do Let's Go, when people talked about these high-level things that schools should do or communities should do. Teachers would come up to me and say, so what's the one thing I can do, Tori? And when we developed these, which are all evidence-based, we realized that giving that teacher or that child care provider the one thing that they may do, I'm going to go back to the 5 priority strategies. So for a teacher, we'd say, don't use food as a reward. And we talk to them about the reasons that that's not a good idea, and then we provide some tools and resources to use other things as a reward. So these strategies took these big lofty ideas that come from the CDC and the IOM and the NIH and put them into doable, actionable items. And this is what we train our staff on in each of the sites, and then this is what we measure. So what we also provide are tools and resources to our sites. So we offer them free to anybody in the state of Maine, and then we offer them online at cost to anybody out of state. And we have a wonderful network of our out-of-state partners from almost all the states. I'm looking at Jackie now, almost all the states in the United States and about 5 to 6 different countries that we partner with, and they use our tools and resources. So that's a very, very brief overview of Let's Go and what our vision and mission is and what we do and how we do it. Now I want to talk a little bit about our highlights and our successes. So we have a strong Let's Go evaluation framework, and our evaluation activities provide evidence of progress and help inform decision-making at Let's Go. So sitting right next to me is Jackie Vine, and that's no coincidence. Jackie is my right-hand person around evaluation. We hired her 5 years ago, and that was one of the best decisions that our program and I have made, to have an in-house person helping us with our evaluation. So here are our 4 elements of the framework. We track the implementation of the program strategies, those 10 that I just mentioned. So we survey sites each year, and we rely on these self-reports to track the implementation of our environmental and policy changes. These changes in the implementation of the strategies leads to something called recognition, which I'll tell you a little more about in a minute. We also track the changes in awareness, so we monitored parents' awareness over the last 5 years using a market research firm's statewide telephone survey. Third, we track changes in behaviors, and we've been fortunate to be able to use something called the Maine Integrated Youth Health Survey data, which is data that's done in schools every other year, and we track our 5-2-0 behaviors. We also look at weight status. So we use the same integrated youth survey that I just mentioned in schools to track obesity for students in the K and then grades 3, 5, 7 through 12. We also use some EMR data, which is awesome, and I'm really excited to use electronic medical record data moving forward. So let me spend a few more minutes talking about the implementation of our survey sites. So as I mentioned, we survey all of our registered sites at the beginning of the year. Again, step 1 is to engage the sites. They have to quote-unquote register with us, which is a very simple process that the Let's Go coordinator does, and they fill out a form. And once they get registered with us, that sort of sets them off on the other steps. But we survey all of our registered sites annually. We also use local and statewide results to report back to the coordinators, and this is something that Jackie mentioned doing about 4 or 5 years ago. So we collect data from 1,000 sites, and then we're able to report it back to just the folks in southern Maine or in eastern Maine or in northern Maine. Even though we're a pretty small state population-wise, about 1.3 million, we're a very small state. We're a very large geographic state, so the people up in the northern part of the state, they very much feel that they're in a different state almost than the southern part of the state, so we wanted to make sure we provided local data back to them that meant something. The interesting thing that we found is the survey results don't always align with the expectations of the people that are in that site, in the site, and also the expectations of the coordinator. Meaning that if you have a site champion and a child care site filling out a survey, and they're filling out the survey, the questions aren't surprises to them because we've been working with them all year, but they might be, all of a sudden things might have changed at the end of the year. They might have had new staff on board, and maybe some of that staff is using food as a reward, and they may be filling out the survey saying, yep, sometimes we use food as a reward, so then they don't get credit for not using food as a reward, right? So the expectation is different when the Let's Go coordinator in that community is like, what happened in Toddle Inn? I thought they were really doing great. I didn't realize that they had, maybe fallen off the wagon on this one piece. So sometimes the survey results don't always align with expectation, and that's also the reason that we like to track it back to local data. We also use the results to determine sites that achieve Let's Go recognition, and I'll talk again about that in a couple slides. So this is another slide that just talks about the importance of the Let's Go survey. And again, we think this survey of implementing the implementation survey to our sites helps build the evidence to support Let's Go and help secure funding to continue our work. The data are presented to the public to educate community members about local progress and to promote Let's Go. The results are used to determine which sites will be recognized, and the results help coordinators plan technical assistance for the next program year. Now on to the survey results that I've talked so much about. So this slide depicts the response rate for our surveys. And the high response rate, over 90%, is due to the incredible work from our Let's Go coordinators. We started doing this work, and Jackie and I couldn't believe back in 2012 that we were getting response rates in the 60s and 70s. And we thought that's pretty amazing for a self-reported survey. In the early days, it was a mixture of electronic and paper. Now it's all electronic surveys. So this is a slide that depicts the program reach. We have, as I mentioned, over 1,000 sites, and we train over 1,400 staff and educators. Our healthcare intervention includes practices in New Hampshire and Massachusetts. And when you just look at the healthcare practices in Maine, our reach is that we're connecting with over 85% of all the Maine children. This is the percent of sites that are Let's Go recognized. So now I'll talk about recognition. So the sites that are recognized are sites that are implementing our strategies throughout their site. So they couldn't just be using healthy foods and for snacks and celebrations in some of the classrooms. It has to be most or all classrooms. And we found out that sites are really, really interested in achieving recognition. We give them a plaque to have in their site. We also put it on our web page, and we publicly acknowledge them through a number of public relation channels. Interestingly enough, it started a couple of years ago that we have parents calling us wanting to know if their child care site is a Let's Go site or if their pediatrician is a Let's Go provider, and we are pretty amazed by that. So we're realizing that the stamp of quote-unquote approval of recognition is helping parents make decisions on where they're sending their kids. So now on to behaviors. So these data come from the MIAS data. That's the data from our schools. It's a statewide data source, and we're only working with about a third of the schools. But here you can see from this slide that 5th and 6th graders have increased their consumption of fruits and vegetables. And we also know that they are consuming the most fruits and vegetables of all the ages, and that as you get older, you consume less and less fruits and vegetables. For anybody who has a teenager at home, you know that it can be difficult to know where and what they're eating and when they're eating their foods. At Let's Go, we use this data to also start to make changes in programmatically how we're going to make some changes to try to increase fruit and veggie consumption as the kids get older. This is screen time. So screen time appears to be moving in the right direction, but screens are quite different. When we started our message and developed the 5-2-0 message now 10 years ago, the screens we were talking about are a little different than the iPhones that all the kids have. But we do know that we're seeing a little bit of at least holding steady on screen time. So this is the one message on physical activity, and there's a lot of work we need to do here in Maine. We really haven't seen the changes that we wanted to see in increasing physical activity. We've been doing some deeper dive and looking into why that is. We also know there's some national work. There's a great new national plan out on how to increase physical activity for youth and families. So we're going to be doing more work on this in the coming year. So this is our zero message, zero sugary drinks, and we've made some real strides where I'm very pleased to see. So there's been significant increases across all grades, and nearly 80% of students don't report that they don't drink sugary drinks on a regular basis. These data points come from the MIAS data also. This is the prevalence of obesity for Maine students over time. And here that the data shows that the kids we're starting to see a downward trend. And again, this is data that it's for all the schools, and we only work with a third of the schools, but we're starting to see some downward trend, which we're very excited about. This is some of the electronic medical record data. We've been following a cohort of practices, not a cohort of patients, but a cohort of practices since 2006. And here we've been able to see no significant change in the prevalence of obesity for all age groups in Greater Portland. And we think this is great. We think this is the first step in making real changes. We are in the next 5 years are hoping to decrease obesity rates by 1 or 2 percentage points. So this is another slide that depicts child obesity prevalence in Greater Portland using that EMR data to the NHANES data. And here what you can see is that child obesity prevalence in Greater Portland has been lower than the national average. So that all sounds great, right? But we've also had our challenges along the way, so I wanted to highlight a couple of them. I think everybody on this call knows this, but obesity is complex. It's not like some of the other public health issues that I've worked on. It's complex, it's multifactorial, and it's stigmatizing. There are many folks who just don't seem to want to really be making changes to make it easier for all children to eat healthy and move more. They seem to think it's a personal responsibility for people who have weight-related issues. I find that oftentimes there's a lack of effective collective impact. I think many on the call probably know about collective impact. It's when we all pull together and collectively come together to make sure our programs are working together, measuring the same things, have reinforcing activities, a strong backbone organization. And this can be very difficult. In our state, we have many wonderful programs, but oftentimes we don't all pull together. I'm happy to say in the next 5 years, we've got a really great plan to do more collective impacts. I'm excited about that. And I will say, though, people often say, Tori, can you actually prove that Let's Go increased fruit and veggie consumption in that one school? That's difficult to prove in that one school. I can tell you that what Let's Go has done to increase fruit and vegetable consumption and doing A, B, C, and D. And I can tell you that people report that they didn't do this before Let's Go. And I can tell you that people say that Let's Go helped them do this. But again, that direct causal effect thing can be very different. Our program was never set up to be a controlled randomized trial. It's more of a community-based, participatory-based research. The third challenge is local data is difficult to access or it's non-existent. And we're really trying to get local data back into the communities, but it's very difficult, and people like to know what's happening in their school, their community. And lastly, it's really difficult and can be very challenging matching funder and stakeholder expectation to reasonable outcomes. It seems to me that every time I talk to a funder or a key stakeholder, they seem to think that we'll be able to stop this epidemic with one grant, one program, and in 1 year, and clearly that is not the case. So I spend a considerable amount of my time making sure that we're matching expectations and the outcomes. And lastly, after the challenges, we definitely have had some key learnings over the years. The consistency in messaging and approach is critical, a positive message, a voluntary approach. Oops, sorry about that. Working across the community wherever kids and families live, learn, work, and play is essential. As a pediatrician, I couldn't just stay in my office and do this work. It's the environment, not the activities. I was at something yesterday, and people kept saying, oh, Tori, I can't wait for you to come to the health fair. That's going to be awesome. And I say, well, that's great, happy to do that, but let's also talk about the environment. So when that health fair is over, the environment is going to support the messages and the activities that we had during that one day. Partnerships and collaborations are paramount. As we say at Let's Go, we'll partner with anybody as long as they're not rewarding kids with pizza parties and ice cream socials. So we really looked at key partnerships and key collaborations. We're very excited about a partnership we have with Good Shepherd Food Bank, which is a major supplier to food to our food pantries. We're doing some really great work with folks who are working in hunger and food insecurity in our communities. This is really important, innovation and risk-taking. Early on when I started to do this work, and Dr. Dietz, Bill Dietz, a good friend of mine, we spent a lot of time back in 2006 figuring out where the evidence was, and we also realized that we needed to start building the evidence. So we've taken a lot of risks. We've had some epic failures, which I can tell you more about, but we've also innovated. We've developed new tools and resources. And lastly, evaluation plays a critical role in our sustainability. I'm not just saying that, but because I'm on this call, it's really critical. I have an opportunity to talk to funders all the time, and they want to see the data. They want to see where we're making change. So evaluation has been a critical role in our sustainability. And with that, I think I will turn it back to Elaine.
Thank you so much, Tori. And Jackie, I know you are there also for questions. That was just so exciting. And we see questions coming in for you. So just a reminder to everyone, if you have questions, please use that chat box on the right of your screen, and we'll collect your questions and share them with Tori and Jackie in the 101 segment. So moving on to our second presentation. Eneli, I'll turn it over to you.
Thank you very much, Elaine. And good afternoon and welcome to everyone joining us for the webinar. Tori, Dr. Rogers, has just presented on a remarkable program with a national scope, statewide and national scope, and measurable impact in several settings. As you listened, you probably were in awe. I was. And for some of us, we wondered, well, how can I pull this off? Like she said, they started small, and we can always start small. So for today, I will be presenting a program that is much smaller than the Let's Go program and may be doable for where you are for some of us. If you have a few committed champions and a healthcare system that wants to make a difference, it can definitely be a start for building that statewide or national program. So in 2010, Ohio State passed the Healthy Choices for Healthy Children legislation, and that was in response to the childhood epidemic. Nationwide Children's Hospital, which is the hospital where I work, was collaborated with several community partners and the health department and the State Department to advocate for this bill. It had three components. One was a ban on sugar-sweetened drinks in schools. Second, assess body mass index and increase physical activity during the school day. For my presentation, I will discuss how Nationwide Children's Hospital integrated these three components, which they were a primary advocate for, into the community clinic partnerships and how we evaluate them. So we'll start with body mass index screening in schools. With the legislation in Ohio, schools can opt in to screen BMIs. And once you screen, you have to create a plan to manage the children identified. So as a part of a multi-sector project with the National Institute for Child Health Quality, NICHQ, we worked with the schools to create a culturally appropriate letter that would go out to parents as well as a script for the nurses to use. Well, we know that the first rule for screening is that there has to be a follow-up plan. Rarely, sometimes, I say often or very often, policy is way ahead of an implementation plan. And I think with the HCHC legislation, that happened a bit. So when we looked at NCH, we had a comprehensive obesity program that provided what called stage 3 and stage 4 treatment for children with obesity. These stages came out of a 2007 expert committee guidelines that looked at the best way to manage children who are overweight, but also children who are normal weight. So in stage 3 and 4, it's a multidisciplinary program, but stage 1 and 2 happens in the primary care provider's office. And for us, it was important that we figured out how we're going to implement stage 1 and 2. We also heard from our providers at that time that they weren't very comfortable with managing these kids in their offices. So the Primary Care Obesity Network was born. And what it is a partnership between primary care pediatric offices and the Center for Healthy Weight and Nutrition. To address childhood obesity, our first scope was in Central Ohio. So the center provides infrastructure and support for the program. And we created a stage 1 program in the primary care practices. In stage 1, the physician provides the counseling for the child who is overweight. And in stage 2, there is a physician or a healthcare provider and then an allied provider. So for PCON, we provide a dietitian to some of our practices. And lastly, we have a concept which I'll talk about later called the patient-centered medical neighborhood, which gives us an opportunity to link PCON, which is the Primary Care Obesity Network, to community organizations. As you can imagine, there are a lot of activities that go with supporting the Primary Care Obesity Network. So Megan Gorby, who is with me on this call, is our prevention coordinator, and she actually keeps it all together and going. What happens in the primary care practices? We have 24 practices to date that are actively participating. They come for annual trainings. For some of our older practices, it's much less time now. We provide a change packet, which just means have all the materials, the resources. We use some of the Let's Go materials in our change packet too, that we provide to our practices. We offer 4 webinars a year, and the topics are dependent on what our providers would like to hear or what they feel will be most helpful. There is an opportunity for a maintenance of certification, which is important to the pediatricians in the group, and we are able to link them back to the center. So if a child is in one of our PCON practices and is not doing well, there is a direct link that goes into the Center for Healthy Weight and Nutrition. Also, we use the same intake survey. So when we look at our data, we can look at it over different practices. These visits are usually about 20 minutes and occur monthly. So this just gives you a graphic depiction of where some of our PCON sites are. A large number of them are related to Nationwide Children's Hospital. They have a big primary care network. And then we have independent private practices. And most exciting for us this year, actually from 2015, is that we expanded outside Central Ohio. So we are now training practices attached to hospitals that are 2 hours away, 3 hours away from Columbus. This is the number of sites that we've trained since we started. We think just given our capacity, it's a pretty good number. It's also a very great group, and we support each other. We had a little lull between 2013 and 2014. And the reason is that our funding changed. So PCON started as a grant-funded program. And between 2013 and 2014, our funding ran out. However, we made a significant case to the hospital, and the hospital adopted PCON. So the hospital from 2014 started underwriting the cost of the program. And here you can see the trained providers and see that it aligns very nicely with the number of sites that we've trained. We have also started training health coaches and school nurse practitioners. So what do we track? We track our behavioral risk factors. We also track goals. And the slide that you're looking at shows you the initial diet and physical risk factors that the families identify in their intake. And the graph below are the goals that they select. And you can see that a large number of our families are eating fried food, drinking sweetened beverages, and not having enough activity or too much TV. In the goals, there was an emphasis, again, going back to fruits and vegetables and limiting portion sizes, as well as the sweetened drinks. We had some interest in increasing physical activity. Now, the next slide looked at a cohort of our patients that attend the PCON practices and looked at if they'd had an initial visit and then 3 or more visits, what happened to their risk behaviors that they reported. And you can see that there was an improvement with a decrease in the number of patients, the number of vegetables they ate per week went up soda went down, and less TV viewing. Now, this may represent socially desirable responses. I mean, we're all aware of them. I mean, we all do it. You kind of under-report what you feel are not very healthy dietary or physical activity behaviors. However, we have a similar slide that I'm not showing today on goals. So we also looked at the goals they selected at their initial visit and if they had 3 or more visits. And the interesting thing was that the data showed an alignment with these reported risk factors. And that tends to suggest that these responses may be true. So it's not unusual for me to see a patient who doesn't drink any sweetened drinks in the office, but yet their first goal is to reduce sweetened drinks. And when you see that, the concept of socially desirable responses comes up. We also look at our body mass index and BMI Z score, and you can see that at least 57% of the patients who had 4 visits or more decreased their body mass index. And when we looked at the BMI Z score, the percentage was much better. However, the results between 6 months and 12 months, those who had 4 or more visits, was very similar. And it could be, when we went back and looked at the data, was that a lot of the visits were occurring in the first 6 months. So the intensity of the dose was much higher. Let's look at the second component of the HCHC legislation, and that is the ban on sugar-sweetened beverages. We partnered when this legislation went into effect. Columbus City Schools banned all sugar-sweetened beverages in their vending machine. And one of the biggest advocates was the city of Columbus. They launched an initiative called Water First for Thirst, which is a media messaging initiative. It reached out to schools, childcare, business organizations, community organizations, and really helped organizations provide water only at events as a resource. The city of Columbus also banned all sugar-sweetened beverages in their offices. So Nationwide Children, which was a partner in this effort, we figured, well, if we tell them to remove sugar-sweetened beverages from schools, we should set the example. And 2010, we banned sugar-sweetened beverages in the hospital. And there's a paper in the American Journal of Public Health which can tell you all about that effort. We found that we reduced intake of soda, the diet sodas, and increased our intake of water. The third component was a nationwide children's, I think that moved. Okay, the third component was increasing daily physical activity in schools. And to do that, the 4 organizations, including Karen Kasich, the Ohio First Lady, partnered to create a series of 5 to 10-minute exercise videos. These videos are free on YouTube and can be used in multiple settings. You can also Google Time for 10 and request a free DVD which will be sent to your family's home or your organization. Finally, my last 2 topics is looking at the patient-centered medical neighborhood and a little bit about our evaluation that I haven't mentioned so far. The patient-centered medical neighborhood is a concept that allows us to create a set of relationships for our families that links the medical home to what's happening in their community. We're very much aware that obesity cannot be taken care of in the 4 walls of a clinic. And the defining feature is that care is coordinated with the medical home, and that care is personalized, it's redundant, and there is consistent messaging in all sectors. So if you're interested in learning a little bit more about NCH efforts with a patient-centered medical neighborhood, this is a CDC publication that is online, and I'm also happy to share it with you if you would like to read more about our efforts. Finally, on measures, we look at the measures for PCON in two ways. We look at our outcome measures. We also look at process and quality improvement measures. And I've presented some of those measures as I went along this afternoon. I'm going to touch on population dose as I wrap up. So one of the things we do to keep it all going is that we use a key driver diagram. It keeps our aims right in front of us. It also allows us to look at what we want to impact, so our primary drivers, and then we look at our interventions. What are the interventions that we're doing, and where is the state of each intervention? So for example, we have grocery tours that we do in partnership with a local organization called Local Matters, and those tours happen at Kroger. So we look at those, we look at how many people are attending those tours, and we try to track the impact. We also create what we call themes, quarterly themes in all our PCON practices for the patient-centered medical neighborhood. So for instance, in May, our theme is usually about gardening and farmers market. One of the things we do as part of the PCMN is that we give MyPlate placemats to all our families that come through. And to assess the impact of doing that, we use the concept called population dose. And you can learn more about population dose. It's from Kaiser Permanente, and it really allows you to assess the impact of each intervention within a program. So when we looked at the placemats that we give to our families, we found that our reach was actually pretty good. Our reach was pretty good. It was high, 95%, but the effect of this intervention was minimal. And that gave us a population dose of 0.48%. Not impressive, but a good way to sit down in our team and decide, do we want to keep doing laminated placemats? And we decided to go ahead because the families liked it, the children found it very helpful, and it allowed us to give them a visual image of the MyPlate. So in summary, I think the most important thing with looking at integrating clinic and community programming is making sure that we're evaluating and appreciating our own capacity and remaining relevant to the community and healthcare system. Thank you.
Thank you so much, Eneli. That was just wonderful. And we've gotten lots of questions for each of you. And just to let everyone know, if we don't get to your question, we'll be answering them with our speakers online after this call. There's one question that's come up for each of these programs, and maybe, Eneli, we can start with you. But participants have asked a little bit more about sources of funding and support. For example, Eneli, you mentioned that the hospital has picked this up, but you know, what happens, for example, with nurses who are conducting outreach? You know, is that, how are these things covered? And then I'll ask a similar question of Tori and Jackie.
Okay. So really quickly, we actually wrote a grant, and we got some foundation funding for the first 2 to 3 years. And the foundation funding was to cover the cost of our dietitians. Our dietitians are in these practices, not all the 25, but most of them 2 times a month. So we're not really talking about a lot of money. Each of those sessions are 4 hours long. And definitely when our funding wrapped up, we struggled with how we're going to continue PCON. I think what this taught us was the importance, if you're part of a healthcare system or a larger body, of remaining relevant and making sure that your program is aligned with the strategic vision and plan of that institution. Because the more you are able to figure that out and also be visible with the outcomes of your program, probably the better chance you have that that institution may want to pick it up and continue.
Great. Well, that's good advice. Thank you so much. And there are a number of other questions, more details about your program that we will be handling online, Eneli. So just after this call, we'll talk to you about those. Tori and Jackie, the same question for you about funding sources and if the program is totally free to the schools and others
Sure.
who participate.
Sure. So we're now getting ready to start our 11th year. In the first 5 years, it was fully funded by a unique partnership with businesses and health care organizations in the greater Portland area of Maine. And then the past 5 years, it was a partnership between those 7 what we call founding partners, businesses, grocery stores, and the hospital. And then within the last 5 years, I worked very strongly to incorporate the program into the Barbara Children's Hospital and matching our program's vision and mission with the Children's Hospital vision and mission, and also with the community health needs assessment that every hospital needs to be doing as part of the Affordable Care Act. So in the next 5 years, so again, we've had this mixture, the diverse mixture of philanthropy dollars. We've also had some grants and contracts from the CDC, the national CDC, our CDC funding, but most of it has been philanthropy. And then the last 3 years going into our next 5 years, we have over half of our operating dollars are now very sustainable operating dollars from the hospital. So I've pushed and nudged, and the hospital has heard and taken this up. And then we have existing donors who have been philanthropy, some foundations, New Balance Foundation, the Walmart Foundation, some Maine foundations, philanthropic individuals, and we're getting ready to have a great partnership with the state of Maine to have some public dollars that will be flowing through. And our programs, all of our professional development we do, all of our tools, resources, all evaluation, all the marketing and media that surrounds all of our program are free to all of the Let's Go coordinators and their programs. All they have to do to agree is to adhere to our program and to make sure that they have a strong team around them and there's a backbone organization that supports them. Oftentimes, we don't pay for the Let's Go coordinators in the community. The community pays for that, and it's usually a hospital or a public health entity.
Great. Thank you so much. To both of you, both wonderful programs. We would have loved to have spent an hour with each one of you. Next time, I think we'll do that because they're so fascinating. And it's really terrific to see that there's just a strong anchor for each of these programs in your hospital, reaching out to the community. It's really what we love to see as we're all tackling childhood obesity and particularly on the prevention side. So thank you both. And again, if you have other questions, please continue to add them to the list. And we will be handling those after the live webinar. I'm sorry we don't have more time because we'd love to hear more from all 4 of you, Tori and Jackie, Eneli, and Megan. This is just terrific. But just quickly, I want to thank you all for your questions. And I want to tell you a little bit about a couple of upcoming events. First, for NCCOR's next Connect and Explore webinar, you can see here it's November 10. It will be part 3 of our series on evaluating healthcare community collaborations. You can sign up for our newsletter, and you'll get an announcement for this webinar when registration is open. You can see to the right a link to the NCCOR website where you can sign up, and you will also see that this Connect and Explore webinar will join others, including the parts 1 and 2 of the Evaluating Healthcare and Community Collaboration series, also on our website. Next, I want to mention that we will be at APHA. We'll be booth 802. We would love to meet you there. So if you are also at APHA, please stop by and what's of most interest to you that we might address. And then I don't know how many of you are familiar with Thunderclap, but we'd love your participation. September is National Childhood Obesity Month, and so to increase awareness of the month, we would love to have you join our Thunderclap and clap and learn more about how NCCOR is accelerating progress to reduce childhood obesity. So you can join by clicking the link and signing up in the box on the right of your screen above the NCCOR website link. And if you do sign up, then everyone who signed up will have tweets going out at the same time, so there will be a huge noise for Childhood Obesity Month. If you have further questions about NCCOR or upcoming activities, please email us at ncor@fhi360.org. Now, we're just about out of time, but I do want to note again that you can see all of our webinars online, and also if you have colleagues who were not able to join today, we'd love for them to hear from Jackie and Eneli if you would send them to the website. And please also stay connected with NCCOR on Twitter and LinkedIn. Visit our blog and sign up for our monthly e-newsletter if you are not getting it. And finally, thank you again for our speakers today and for all of you who joined us to listen in. Please take a moment to complete our brief 6-question survey so that we can hear from you to help shape future webinars and make sure we make the best use of your time. So we're going to switch over to the feedback form now, and please write your input directly on the screen and then hit submit. Again, thank you to Tori and Jackie, Eneli and Megan, and all of you who joined us, and have a good afternoon.